I would like to introduce our first speaker of the afternoon, another outstanding CSF leak researcher and physician from the Netherlands. Another one from the Netherlands, not Belgium. Dr. Eef Hendriks, Assistant Professor, Division of Neuroradiology, University of Toronto, University Health Network. We're looking forward to it.
Thank you, Dr. Carroll. So I'll be talking about the embolization of CSF venous fistulas for the next 15 minutes. I have no conflicts of interest. 15 minutes, yeah. So today we'll talk about the short history of about 5 years that we're doing these embolization techniques for CSF venous fistulas. We'll be talking about the beginning period, the first couple of years in which we gained experience, and then also the more experienced period, the last 2 years. We'll be talking about the outcomes between those two periods, and of course the most common complications that we've seen in the patients that we've treated so far at Toronto Western Hospital. The technique was developed by Dr. Walid Bringici in 2020, 2021. He works at the Mayo Clinic, and the idea is basically to close the back door of a CSF venous fistula via the vein. So you go with a microcatheter in the paraspinal vein, and you either inject a liquid embolic material, plus or minus coils, to induce thrombosis. Yeah, mine are following, yeah. No, I'm at the fourth slide. So the technique was introduced by Walid Bringici in 2020, 2021. And what you basically do is you navigate with a microcatheter in the paraspinal vein, and you inject an embolic liquid material of your choice, plus or minus coils, and you introduce thrombosis. And initially the target was just the paraspinal vein. So that's what we kicked off with in 2021, 2022. By embolizing these cases. This is an example case with typical finding of subdural hematomas, sagging of the midbrain. The spine was negative. This is the correlating myelography that was done, demonstrating a CSF venous fistula. It might be difficult to see, but this is the magged up, where the red arrow is. And initially we went in via the groin, into the common femoral vein. We worked our way up. You kind of make a 180-degree U-turn the way down into the azygos system. And in this case, we embolized the hemiazygos vein and the paraspinal vein. That was in the beginning period the target for the treatment. This patient did well. The symptoms resolved. The imaging findings went away. You can see that on this follow-up CT that the sagging was disappearing. And then also via the publication from the Jacksonville Mayo Clinic, we came up with the idea of doing a venous pressure cooker technique in 2023. This is another case with very thin subdural collections. There's some distension here of the venous plexus below the anterior pituitary lobule, and there is a blown up aspect of the superior sagittal sinus. Again, for this case, the spine was negative. This is the correlating myelogram showing a leak at this level, where the arrow is, the right T10 level. And then we switched the axis of the procedure. We didn't go in via the groin anymore, because sometimes it took a while to make the hairpin curve from the superior caval vein into the azygos system. So now we go into the right upper arm, into the basilic vein. Then you have a very stable axis. You just got to go down and posteriorly to get into the azygos system. And in this way, we also had better access with larger guide catheters, with which you can do a very nice venogram. and you get a better understanding of all the veins that are there in the paraspinal area. On the right side, you got the azygos vein, which is a big collector, and that transcends into the right ascending lumbar vein at the thoracolumbar region. On the left side, there is the hemiazygos vein. And then if we go further into detail, at each level, there is usually a paraspinal vein that is draining the foraminal venous plexus. And the foraminal venous plexus is kind of an intersection between the intercostal veins and the epidural veins. The epidural veins, they drain the horizontal and the lateral anterior epidural venous plexus, as well as the bridging veins. And the bridging veins are the actual veins that drain the spinal cord, but you usually don't see them in physiological conditions, and you don't see them in patients with a CSF venous fistula. Only in patients, for example, with a spinal dural AV fistula or a spinal epidural AV fistula. So then we switched the area of interest for the embolization from the proximal ligation of only the paraspinal vein to the foraminal venous plexus. And the way we approach this is a magnified venous injection of that area. And here you can see that the venous flow is kind of bidirectional, which means that potentially CSF that's leaking into that area can also escape via different routes. So what we did then is we embolized the intercostal vein with coils. We embolized the epidural vein with coils, and then we put a balloon mounted or balloon guided microcatheter in the paraspinal vein, and then you inject the onyx to form a nice cast around the foraminal venous plexus. And onyx is a liquid embolic material that kind of travels in layers, and it's a composite of a polymer and DMSO. That's the substance that keeps the onyx liquid for about 20 minutes. And tantalum powder, that's actually the substance that makes it visible on the X-rays. So this is the technique that they described in Jacksonville as the venous pressure cooker technique. Unfortunately, this patient, this is the cast, and here you can see that the foraminal venous plexus, where we think the leaks are usually, is kind of surrounded with embolization cast. This patient unfortunately didn't improve, and the imaging findings also stayed there. So in the beginning period, we had varying outcomes in terms of symptoms and imaging findings. So then we came up with a different technique. We called it the multi-level and multi-venous outlet technique. This is an example case of a patient that had subdural collections on both sides. The spine was negative. This is the corresponding myelogram showing a high flow CSF venous fistula at the left T11 level with a contrast present in the kidneys. And during these venous injections, we kind of figured out and realized that the venous anatomy is more complex and more developed than we think. There's dozens of visible connections, but there's also dozens of invisible connections because the blood is flowing towards the catheter. It's not such as an arterial injection where you see all the vessels usually that are out there. Not only we see the paraspinal vein, but also the foraminal venous plexus, the epidural veins, and at some levels there's no epidural veins, and at some levels there's a dozen of epidural veins. So when we realized that, we started to do more invasive embolizations because we think that the site of the fistula can also drain into dozens of directions. It's not only draining laterally, because if you close off the lateral exit, then it might drain medially or up or down. So we approach it like a big roundabout, like the one in Paris. So for this technique, we embolize at least the level of the fistula. We embolize one level below, one level above, and we also try to at least embolize the anterior epidural venous plexus, which is usually affected in patients with a more medially type of fistula that Andrew spoke about this morning. So we basically build a whole cast, and we try to obliterate all the veins that are in that area. And this patient did well. The symptoms disappeared, and he was discharged. This was a patient that was in ICU. So from the first period, from 2021 to 2023, we had a handful of cases. About 60% improved, and 40% did not improve. And with a more invasive or aggressive technique, approximately 90% of the patients is symptom-free. There was one case that improved significantly, but that was a case where we weren't sure exactly where the site of the fistula was. The advantage of this multi-level, multi-venous outlet embolization technique is that there's a high chance that you close the fistula. You can see that the onyx cast is way more extensive as with the embolization that we had in the beginning period. With this technique, we navigate in the dilated epidural venous plexus to the site of the CSF venous fistula. We use this when there's difficult access. For example, this was a case where the site of the shunt was at T6. We couldn't get there, so we went into the epidural venous plexus at T10, and we used a microcatheter. It might be difficult to see, to navigate all the way up, to take kind of the elevator in the anterior epidural venous plexus to the site of the leak, and there we embolize. We try to use 2 microcatheters, one to go down. So this is the trajectory that we take. We take the paraspinal vein, the epidural vein, and in the epidural venous plexus we go down, and with the other catheter we go up. And in that way we can perform a very controlled embolization of all the structures that we want with the onyx. Another advantage of this more extensive technique that we think that we both close the lateral type of fistulas that are typically below the pedicle, but also the more medially located CSF venous fistulas. There's 2 examples of that. This is a case that we still have to treat. And very late in the myelography run that Dr. Farb did, you can see that there is a string of contrast dye going more medially, corresponding with leakage of the dye in the anterior epidural venous plexus. So this leak, I think, is more medially than the more conventional leaks that are laterally. This is another case that we referred to Duke for a photon counting CT because we couldn't find the leak. And if you slowly go through, there you see that there's leakage of the dye more medially on the inner side of the pedicle into the anterior epidural venous plexus. This patient was treated abroad, got the symptoms back, so we did a re-embolization, and we targeted this area. So this is also a graphic that Andrew already showed this morning. The idea is that you don't only have the lateral types of leaks, but also the medial types of leaks. And if you do more extensive embolizations, then you're more sure that you take both of the areas out. And the existence of the lateral leaks was already described by Peter Krantz and Wouter Schieving with this hyperdense paraspinal vein sign, and the more medial types of leaks was described by the German group with the hyperdense basivertebral vein sign. Nevertheless, we have to keep in mind that these more extensive embolizations are more invasive. The patient is longer under anesthesia. I like to do it under anesthesia because the embolizations can give pain to the dura. There's more embolization material that we use, and there's also more radiation exposure. So when I went back to the cases that we did at the Western, a significant amount of patients, they have local back pain for weeks, and sometimes it also radiates as a band over the chest. If it's, for example, a thoracic level fistula, many patients have rebound hypertension, which is a good sign. But the headache is uncomfortable, so we prophylactically already put them on Diamox. And then we had one unfortunate case of a complex venous anatomy fistula that took us a long time, that developed radiation dermatitis due to the length of the case. So in sum, this multi-level and multi-venous outlet technique that we're using is quite successful. It treats the lateral types of CSF venous fistulas and the medial types of CSF venous fistulas. However, we need to keep in mind that these embolizations are also more invasive. And with that, I'd like to thank our patients, Dr. Farb and Dr. Najwala, for doing the diagnostic workup, which is more difficult than the embolizations, and the SIH team. Thank you very much.